Hi guys, welcome to ALHT 209, and this is our PowerPoint presentation for Chapter 5, Hematology. And as always, we talk about our learning objectives, right? Because you guys need to understand that when we go through this material, these are the things that you're going to learn at the end, right? Everything from identifying proper specimen collection for hematology testing all the way down to completing the documentation used for hematology testing. And remember, Chapter 5 on page 113 in your textbook also lines out all their objectives, because we always want to understand what we're trying to learn, right? Also, at the top of page 113 is all of your key terms. Guys, if we want to speak intelligently to our co-workers, physicians, and patients, and for us to be able to really understand this information, the first thing we have to do is understand the language. We need to know these key terms and what they mean. There's also a set of abbreviations here. These are also very important for us to learn and understand. Your textbook is a great companion to this PowerPoint presentation. Please make sure you read your chapter first in your textbook, then watch this PowerPoint presentation. As you're watching it, get out the review guides that are in your black binder for Chapter 5, and make sure you fill in those review guides. Once you finish this, then you can study those review guides for your test. Remember, guys, if we were in the classroom, we cover about a chapter a week, and we would meet on Mondays and Wednesdays in the classroom. But due to COVID, this is an online test, so we will cover a chapter in about a week, and you're in class for about an hour. So most of these videos are a little bit shorter than they would be in the classroom, because sadly we won't be able to interact with each other in lecture like we will in lab, so you can't ask questions and things like that. So I love the fact that it takes longer when I'm actually in the face-to-face class. The good thing is, though, we get through these PowerPoints, you guys can pause them, rewatch them. You can watch a little bit of it and fill out some of your review guide, go take care of your children or whatever you need to do, and come back to watch the rest of it. But the sooner you can read the chapter, the sooner you can watch the PowerPoint presentations and fill out the review guides, then the sooner you can just start going over those review guides over and over, because that's the information that your test is based off of, so that you can make sure you learn the material and make good grades on your test. Okay, so let's get started. We'll go through these things as quickly as we can, because you guys do have the ability to pause these so that you can look over that information. So the first thing, like I said, are the key terms. We need to understand what these words mean before we start putting them together in concepts, right? So guys, I'm going to just quickly go through these terms on here. The reason I even put these on the PowerPoint presentation is so you guys could use this as a tool at home to study. Because once you've learned your key terms, you can pause this right here and read it. You can say fluid within the cells are called, and then you can take a piece of paper, write down what you think the answer is, and then restart your video, and your answer comes up. And then you can see if you're learning these key terms. So I'm going to go through each one of these, guys. You take the time to pause it and see if you're getting the correct answer. You need to learn your key terms. Okay. So again, you can rewind these, pause these, guys. Take out a piece of paper on those key terms. And like I said, what you need to do first is read your chapter in your textbook. Then watch the PowerPoint presentations while you're filling out your review guides. Then study your review guides. but you can use a lot of these slides in here. I put up review slides, a lot of them, because I know when it's at home, especially during COVID, sometimes you don't have the availability to have a study partner to go over things, and these are like using index cards to study this material, okay? So let's get started on chapter 5, okay? This is an overview of hematology and blood. Guys, the classes that we set up for you at BIPSI all go together to build a complete puzzle. So when you take classes like anatomy and physiology, they go together with my overview of this for you all to put it together and continue to learn this material. So the first thing we need to look at is hematology. What is hematology, right? It's the study of the cellular components of the bloodstream and your bone marrow. And remember, a hematologist primarily studies the cellular elements of blood, but they also investigate the hemostasis of the blood, okay? And we need to know what hemostasis is. We've learned about homeostasis, right? The way our body overall keeps everything in line, keeps our body temperature at a certain level, our pH at a certain level, our blood pressure, sugar levels, all kept at a certain level to keep that normal stasis, right, over our whole body. Where hemostasis, it's the ability to keep our blood in a liquid form as it flows through our blood, but to also start the clotting process and stop the clotting process when needed. So make sure you understand that hemostasis is a part of the overall homeostasis, okay? So we're going to look over some of the tests that are out there that you could be doing in a laboratory and why we do them, okay? And what specimens we do them on. So the first thing we're going to look at is the complete blood count, or the CBC, right? Now the CBC is a moderately complex test. And we'll go over later what are some of the things that need to be done when you're doing moderately complex tests, right? And they're used to evaluate the health status of our patient. Now remember, the differential count is a part of the CBC, right? And we can have an automated differential count. That's the count that comes out from the instrument. The instrument itself does a differential count and it prints it out on the report form, okay? And then we can also do a manual differential count. That's where we make 2 blood smears, stain them, and a med tech or an MLT or a physician does the count off of that blood smear, off those blood smears, okay? CBCs are done off of purple or lavender type tubes because EDTA, which is an additive in that tube, right? But that additive is an anticoagulant. It stops the blood from clotting. We use EDTA because it helps maintain the cell morphology of our cells, and we want them to look as good as we can so that we can identify them on our slides. So remember, blood is a complex liquid tissue. Okay, I know that's hard to imagine sometimes, but blood is a tissue. It's just liquid, in liquid form. And it's continuously flowing throughout our vessels, right? And the blood consists of formed elements, right? So we have the liquid part of the blood and then the formed elements part of the blood. So the formed elements are the solid parts of the blood, like our RBCs, WBCs, platelets, right? These are the things that we can see under the microscope and we can distinguish between each one of them. But we need to remember that those formed elements are suspended in the liquid portion of our blood, which is called plasma. Okay, and you'll see this little thing down here, and it's also on page 115 of your textbook, and we can see that the blood as a whole is made up of the cells, right? And then it's made up of the plasma. And what we need to understand is the plasma is made up of several things. It's made up of water, salts, nutrients, and hormones, and vitamins. But it's also made up of proteins, okay? And then there's all those other proteins that are under there, okay? Things like clotting factors and other stuff like that, okay? So there's a really even better picture of it, like I said, in figure 5.1 on page 115 of your textbook. So where are the blood cells produced, right? And you also see that on page 115 as well. It shows you pictures of highlighted areas of your skeleton where you make them. They are made in the red bone marrow, which is found in flat bones and at the end of long bones. Okay? So we also, we kind of want to go over how they originate, right? All of our cells, whether the red cells, white cells, or platelets, come from a hemocytoblast. I never can say it right. I get in a hurry. The hemocytoblast is also the stem cell. Okay, the stem cell is that cell up at the top. Okay, so if you look in your textbook on page 116, figure 5.3, there's really good laid out picture. Okay, the stem cell is that beginning cell. Okay, all other cells come from it, right? And you'll see how they matriculate down on page 116. Okay, so let's go through this, how it changes through each one of these visible stages down to its mature red cell, white cell, and platelet. Okay, so also I always want you guys to learn how to speak intelligently, like I said, to your co-workers, your physicians, and to your patients. And learning these key terms and then being able in your own words to describe things is going to be really helpful for you. So make sure as you're going through these review guides, you fill out these spaces in here for homework, right? You want to describe hemocytoblast in your own words, and you want to tell why stem cells such as the stem cell, the hemocytoblast, are important to research, okay? So you want to make sure your answer contains that it is the most immature blood cell. All other blood cells come from it, right? And you want to understand that because it hasn't coded yet, right? It's uncoded. It hasn't made the decision right yet. It hasn't coded itself yet to become a red cell or a white cell or a platelet. So because of this, they may be planted in the body of a person with a congenital defect, and those stem cells will reproduce and function normally in the affected area that they are placed. Okay guys, let's talk about our RBCs, right? We know that the bone marrow is constantly producing new RBCs. And the beginning stages of the RBC production in the bone marrow, right, are shown on this figure, right here to the far left-hand side. We know that all the cells come from stem cells, but once it encodes to be a red cell, the first stage is the erythroblast or ruboblast. And blast means immature, right? Then it becomes the normocyte. That normocyte then sheds the nucleus before entering the bloodstream. In the bloodstream, the young RBCs, which still contain some nuclear remnants, are called reticulocytes. The average number of reticulocytes found in the peripheral blood is approximately 1%. So you will see some of those of the immature red cells in the bloodstream, but it should be a very low number. The most you're going to see is the most mature section of the red cell, which is the erythrocyte, right? Which is that biconcave disc, right? It's got that reddish pigment to them, which we call hemoglobin, right? So we understand that mature RBCs contain that hemoglobin, right? That gives it that pigment. There's millions of molecules of it. It's its oxygen carrying capacity, right? So now we know where it comes from. We know how it matriculates through there, right? Now what happens when those RBCs die, right? We know RBC's lifespan is about 120 days. And our bone marrow is constantly making new ones, right, as they die off. But what happens to it when it dies? Okay, so it releases the iron portion, which is heme, right? And the protein portion, which is globulin. The globulin is sent to the liver as bilirubin, okay? And then it's further metabolized, which we understand metabolized talks about breaking down. It's further broken down in the liver, the intestines, and the kidneys. So the heme is just released, right? That's the iron portion. And then the globulin is sent to the liver as bilirubin, and then it gets broken down further and further, right? So we know we have these critical thinking slides, right? These are ways for you to learn everything everything you're learning in lecture and lab, and put it together to see if you can answer these questions and deal with these situations that you may encounter out in the field. So what I would like you guys to do is take the time to pause these critical thinking slides, read them, and see if you're getting the correct answer. So why don't you guys get you out a piece of paper, pause this now, read through it, and see if you get the right answer. Okay, guys, we know that it's heme and globin. When that red cell is broken down, right, it's going to release the heme portion out into the blood. The globulin is going to be packaged up as bilirubin, sent to the liver, right? It's further broken down in your intestines, right? So now let's move on to making blood smears. So we've talked about our red cells, how they mature, where they come from, the process that goes through. We've talked about what happens when they break down, right? How our body takes care of them and gets rid of them, right? Now, if you look at the bottom of page 119, it shows you the way to make a slide from a purple top tube. And then if you'll turn to page 120 and 121, it gets lots of really good examples of how to make a slide, the different bad and parts of what the smear would look like. And even down in the bottom of page 121, it shows you a differential counter and a microscope, the two things you would need to do your differential count. Now, like I talked about, there's an automated differential count that you get from your instrument that it does itself. Then you make 2 smears and you can do a manual count, right? So that manual or that differential count is looking at the 5 different types of WBCs, okay? It wants to count those and see which ones you have, and then also scans that slide for RBCs and platelets, okay? So how do we collect that blood, okay? We can either do a finger stick, where we would make our 2 blood smears first, and you guys have seen these smears. They're on page figure 513 on page 121. What you do is there's a frosted or a white edge at one end that you use to label your slide, right? You write your patient's name, date of birth, and your initials as the person making the slide in that frosted or white area. Then, when you stick your finger, you put 1 drop of blood as close to that as you can, all right? Then you take your pusher slide, you put it in front of your drop of blood, and you want to do this stuff quickly, right? It takes practice. This is an art. Then with it tilted, okay, then you're going to bring that slide back, and as it touches that drop of blood, it will start to move across the slide, and then you push the slide forward, going all the way across the slide off the edge. You don't want to push down hard with that slide. You just want to push it all the way to the end in one smooth motion, okay? If you were sending it off to a reference lab, or if your physician's office happened to use venous blood from a purple top, you could collect a purple top, and you could even make the 2 slides from the purple top using the method you see at the bottom of page 119. And it shows both how you do it from a purple top and how you would put that drop of blood onto a slide from a finger stick. Figure number C at the bottom of 119 is a really good picture of how close you put that drop of blood to that frosted end of that slide. So here's our critical thinking activity, okay? So make sure you pause this, read through it, and see if you're getting the correct answers. So we talked about RBCs, how to do differential counts. Now let's talk about WBCs. So again, all these cells come from the stem cell, right? So we know that that stem cell up there at the top can decide to be that red cell or it can decide to be a white cell, right? So remember, white cells are divided into two groups. We have granulocytes, which tell us we're going to see granulars, right, in the cytoplasm, or agranulocytes, which is telling us that we won't see granulocytes in the cytoplasm, right? So what are the cells that eventually mature into the granulocytes? And what are the granulocytes? The granulocytes are our neutrophils, our eosinophils, and our basophils, right? And then what are our agranulocytes? There are monocytes and lymphocytes, okay? Myeloblasts mature into myelocytes, then a band or a stab cell. It's similar to the red cell, guys, that last stage, and you'll see it here on your figure here at the top, right? So it shows how we go from a stem cell to a myeloblast to and again, guys, even a better picture of it is on page 116 in your textbook. But it goes, like I said, from your stem cell down to your myeloblast. And then from your myeloblast, it breaks off. And you see it be your basophil, which is your metamyelocyte, neutrophil metamyelocyte, and your eosinophilic metamyelocyte, right? Then from there, it can go break off even more, right? So it can be your band cell. From your neutrophilic metamyelocyte, it goes to a band cell, then to a segmented cell. Now let's talk about that first, because I want to make sure you guys understand that. Remember when I talked earlier, when we were talking about RBCs, and I was talking about how your reticulocytes you can see about 1% of your red cells be those immature reticulocytes in your bloodstream when you're looking at your blood smears. It's similar with that band cell. You may see some band cells in your blood on your blood smears, okay? But it's always going to be a much lower amount than your most mature neutrophil, which is your segmented neutrophil. So remember, and I'm saying this because I want you guys to understand it, okay? When you're talking about red cells, you will see about 1% when you're looking at your smear of reticulocytes, because about 1% of that immature reticulocyte will be in your bloodstream. But you're going to see a bunch more, obviously, of the erythrocytes, right? Only about 1% of your total RBC count under the differential cell would be your reticulocyte. So remember, when we're talking about the neutrophils, okay, the most immature of the neutrophil is that band cell. But you will see quite a few band cells when you're doing your blood count, okay? Not as many as the neutrophils, but you will see quite a few of them in there. And I just want y'all to understand that part. And then again, down there at the bottom on the right-hand side, that's what a band looks like. It almost looks like a band that would go around your finger, okay? So you will see that a percentage of that is normal in your on your differential count. So guys, I want you to be able to identify these WBCs by sight when you see them, okay? So make sure, what I'd like you to do right now is take that piece of paper you've been working with and either download the bottom or over on the back or get a new piece of paper, pause this, and see if you can answer what this cell is. Okay, now we're talking about the mature granulocytes, okay? So the PMN, that polymorphonuclear cell, or a segmented neutrophil. Either one of those names means a mature segmented neutrophil. This is at its maturest point, right? And we call it a seg because you can see the nucleus has segmented into 3 different sections, right? So it's a segmented neutrophil. As before, when we showed the band, it was just one full nucleus, right? So this is the mature one. Okay, so now we're going to name and describe the 3 granulocytes and tell the function of each. So we have neutrophils like we talked about, eosinophils, and basophils. Now remember, and you can see this on page 116, figure 5.3, your mature basophils and your mature eosinophils, they don't go through that band part, right? It's that neutrophil that goes from that metamyelocyte phase to the band cells, which is that most immature right before it's the most matured in the segmented. But you don't see that in the basophils or the eosinophils. So these are our granulocytes, right? Because if you will look, now here's the photos. Over on the right-hand side at the top, we see the segmented neutrophil, which gives it away for us that this is a neutrophil, right? Because the nucleus is segmented. Also, those lavender pink, really fine granules in the cytoplasm, so we would know this is a neutrophil. Now, right below that, we see the granulars are much more prominent, right? And we can still make out the segmented neutrophil, but we see that those are really red granulars, right? This tells us that this is eosinophil, and it's associated with allergies and allergic reactions. So if we see an increase in our eosinophils on our differential count, this might, we put with other things, we might put this together with somebody having allergies or an allergic reaction, because we need to go off of other things like signs and symptoms, right? And then that bottom cell over to the right-hand side with the much bigger granulars in there, right? They're staying really that dark blue. That one is our basophil, okay? Their granules help produce heparin, okay, which is a naturally occurring anticoagulant within our body that aids with our hemostasis, which is keeps our blood from overclotting, right? So get out a piece of paper, label it 1 to 4, pause this video and see if you are labeling each one of these cells correctly. Go ahead and pause it now. Okay, guys, so you need to be able to identify these WBCs on site. You need to know what they indicate, right? And we need to understand that these are our granulocytes. Neutrophils, basophils, eosinophils, and the immature neutrophil is the band or stab. So now let's move to our agranulocytes, our monocytes and our lymphocytes, right? So with the monocyte, that's the cell at the top on the right-hand side. It is the largest WBC. But the thing you need to understand about that monocyte, it is able to leave the bloodstream and go into the tissue. Once it does that, it's referred to as a macrophage. And it's associated with cleanup and recovery stage of tissue damage. Okay? Then that bottom cell down there, okay, it's the smallest of the WBCs, and that's our lymphocytes. And remember, it comes from the lymphoblast, just like the monocyte comes from the monoblast, right? And we see pictures of that on page 116 in our textbook, right? Again, like I said, that lymphocyte is the smallest cell, and you can even further break down the lymphocytes into B lymphs and T lymphs, right? B lymphs and T lymphs and lymphocytes in general play an important role in your body's immunity, but they're also associated with viral infections. So again, if you see an increase in the percentage of lymphocytes in your differential count, this along with a lower overall white cell count, along with other symptoms, could help our doctor diagnose a patient with a viral infection versus a bacterial infection. Because we remember that our neutrophils, if they are higher than normal average on our differential, and we have a higher overall white count, that could help with symptoms, lead our doctor to diagnose our patient with a bacterial infection. And we don't want to give antibiotics to a patient who only has a viral infection, because it won't help them, and you don't want to give them medicines they don't need, right? But we want to make sure if they have a bacterial infection, they get an antibiotic to help get rid of that bacterial infection. Again, take a piece of paper, label it 1 through 6, Pause this video and see if you can label each one of these cells correctly. Okay, guys, remember, we do our differential so that we can count our WBCs and give a percentage of each WBC. We have granular sites, which are stabs, which are the immature neutrophils. Then we have the neutrophils. We have eosinophils and basophils. And remember, our neutrophils are the ones that increase in percentage when we're fighting off a bacterial infection. Remember, our eosinophils increase in percentage when we have an allergic reaction to something or we have allergies, seasonal allergies. Remember, our basophils help produce heparin, which is our body's natural occurring anticoagulant that helps us maintain maintain our liquid form of our blood so it doesn't overclot, right? And our monocyte and lymphocyte are our agranular white cells. And remember, the monocyte is the bigger one, the lymphocyte is the smaller one. The monocyte can remove from the bloodstream into the tissue, turning into a macrophage that helps clean up debris and helps in the recovery phases of tissue damage. And our lymphocytes can be further broken down into B lymphs and T lymphs. They help in our immunity, play a key role in that. And they're also elevated in percentages when we have viral infections. So here's that critical thinking time when you take the things that you're learning in lecture and lab and put them together to see if you can use them out in the field when you're caring for your patients. So pause this video now, read through this scenario, and see if you can get the right answers. Guys, you should see a trend here. When we talk about how should the blood be collected, right? Either a purple top in 2 smears or a micro container in 2 smears for any type of situation here, right? And you need to understand that when you see an increase in the neutrophils, right, it's a bacterial infection. When you see an increase in the lymphocytes, it's a viral infection. If you see an increase in the eosinophils overall, it could be allergies or an allergic reaction. So let's move on to our platelets, right? And again, on page 116 at figure 5.3, over to the far left, we see that setup of the megakaryoblast, right? First is the stem cell. Then it decides it's going to be a platelet. So the first thing it does is it becomes the megakaryoblast, right? Which, if you look down at that bottom picture to the far right with the little arrows are pointing, I always find it odd that that little bitty chip of a little purple dot is a platelet, a mature platelet, and it came from such a big cell, which up at their top over to the far right is the megakaryocyte. The little platelets are pieces of the cytoplasm of that megakaryoblast, okay? And on page 116 in your textbook, you see the megakaryoblast, then it becomes the megakaryocyte, and then it becomes the platelet, right? And we know that the function of our platelet is to aid in the clotting process, right? And the way it aids in that is that when you cut your blood vessels, the platelets run to that hole and start becoming sticky and clump together to plug up the hole. They also release clotting chemicals that cause the formation of a clot that entangles the blood cells. So they play a vital role in the clotting process. So here's another one of our critical thinking slides. Guys, pause it now, read through it carefully, and see if you're putting all this together. We need to be able to spot things like this. If we see petechia on our patient, we need to understand that they could have a clotting issue. And we want to make sure we prevent damage, any further damage to our patient. So if we see this, We don't want them to then get a big hematoma and bruise, so we may need to hold pressure longer than normal on these particular patients. So we went over how to make this slide, right? We went over, and like I said, there's great pictures in your textbook at the bottom of page 119, 120, and 121, right? And we'll make these slides in lab as well, okay? But you put that drop of blood is placed on one end of that slide down near that frosted or white edge where we put our patient's name, date of birth, and our initials, right? We take the pusher slide and it's put in front of the blood. We pull it back into the blood drop. It starts to run across the slide, and as it does, we push that slide to the other end of the slide, moving in one continuous motion off the edge of the slide. Okay? And you never want to put too much pressure down on that slide, or it will be too thin, or it causes other problems and you won't get a good slide made. So here's an example of you make two slides, right? You see that drop of blood, the thicker end is down near that frosted end. And after you've collected these slides, you will label them with your patient's name, their date of birth, and your initials. That's the person who made that slide. You want it to be smooth, not wavy, okay? You want it to go from thick to thin. Overall, not too thick or too thin, okay? You don't need the smear to be really overly thick or overly thin, but it does need to go from thick to end, thick to thin, and it needs to end with a nice feathered edge, okay? It needs to cover at least half of the slide, but not the entire slide, because if you try to cover the entire slide, you won't end up with a nice feathered edge at the end. So once you make your slide, you want to stain them, right? Because our granulars stain different colors, right? So you'll see there's 3 containers here on our Diff Quick. This is the stain used to stain blood smears, Diff Quick, right? That first clear container is what we dip our slides into so that the blood is fixed to the slide. If not, when you go to dip it into the stain, it will just wash the blood away, okay? So you must fix the stain first. Again, okay, I want you to be able to identify the WBCs and tell the name of each one. So pause this slide and see if you're able to do this. Pause it now. Okay, guys. You have 5 mature white cells: the neutrophil, eosinophil, basophil, monocyte, and lymphocyte. But you also need to be aware that you could see some stab cells, which is your immature neutrophil. Be able to spot these and name them. So now when we're talking about these differentials, right? Can a medical assistant or a lab assistant perform a differential? No. Clea says no. They can prepare the slide. They can make the slide and prepare it by staining it, right? And you guys have been checked off on being able to put your blood smear slide onto your microscope and being able to focus it in on all the way up to oil immersion, right? And then your hematologist, your clinical laboratory scientist, your physician can come over, and then they themselves will do the differential. If you work in a lab where they don't do those, then lots of doctors just take that automated differential they get from their instrumentation. Okay, so how is this performed? Okay, because this is just knowledge. You guys need to know how this is done, okay? So what you're going to do is look down into your slide, right? And it's that round circle. It doesn't really look square like this. It's more round. But you're going to go like a snake serpentine-like pattern under oil immersion, okay? And you're scanning this slide, right? Each time you come across a WBC, and we see we have 2 neutrophils and a lymphocyte right there, right? This counter down below there, you have it all zeroed out when you start. So from this one slide, you would hit the neutrophil button twice, the button that corresponds with the neutrophil on this counter. You would hit it 2 times, and you would hit the little button that corresponds to the lymphocyte once, okay? You would keep doing this. As you're doing it, you're going to observe your platelets and red cells too, and we'll go over what you're looking for. But when you have counted 100 white cells, that bell's going to ring, okay? The results above each key indicates the percentage of each one of those white cells in your blood smear. So these are the types of WBCs in order of highest percentage to lowest percentage, okay? So when you're doing your differential count and you count it all and it dings and it's at 100, when you look down, the one with the highest normal, highest percentage is going to be your segmented neutrophil, which we know is our mature neutrophil, right? It's going to be the highest. Normally, even if our patient is totally normal, that's going to be the most cells you see. That's going to be the highest percentage. Next would be your immature neutrophils, which are your band. Then next would be lymphocytes, monocytes, eosinophil, and the rarest one seen, it will be the lowest percentage of the 100 cells will be your basophil. Okay, now also when you're counting all these white cells up and identifying which ones and reporting them out as percentages, right? You're also going to be looking at your red cells. You're going to look at them to see, are they macrocytes, microcytes, and in other words, there's normal RBCs. Are these too small? Are these too large? Are they just an abnormal size? Okay. Are they shaped differently? Are they spherical? Are they ovals? Are they look like little targets? Okay. Are they abnormal color? They could be polychromia or polychromatic, which would be different colors all over the place. Or lots of hyperchromia, which is they're really red, right? Or hypochromia, which is less color, right? Then you can have stuff like basophilic stripling, which are small RNA dots that you see in the red cell. And of course, there is sickle cells, which kind of look like a C, like a sickle, right? You want to note any of the abnormalities you see in your red cells, right? Because they can help our physician with their diagnosis. Also, the hematologist or the clinical laboratory scientist will do an approximate count of our platelets. So, talking about the theory of hemostasis, right? So, think about this. When the blood vessel is damaged, your body's going to send out that red alert, right? So immediately, the first thing that's going to happen is that blood vessel wall is going to contract because we want to slow blood flow to that area because we don't want it to just bleed out, right? Simultaneously, those platelets are going to become sticky and they're going to flow to that area to try to form that platelet plug and stop up that bleeding area, right? They will also release some chemicals, right? And then that clotting factors form, goes through this cascade, and it forms the more permanent fibrin clot. Okay, you guys have probably seen this before. You cut yourself, it bleeds, it forms that little platelet plug, then you get a really hard, what most of us call a scab there, right? And if we leave it there and we don't pick at it or it doesn't get bumped off by something, right? Because if we bump it off sometimes, it'll start bleeding again, right? But what happens if you just leave it there? It's slowly but surely, as it's doing its job, it will start to get smaller and smaller because that cut is starting to heal up. Underneath that fibrin clot, your body's doing the job to repair that opening in that vessel. And once it has completely closed up and it's not an opened cut or wound any longer, then that clot will shrink all the way up. It will dissolve and just fall off on its own, and it won't be there. It's no longer needed. Okay, guys, it's a very complex process, the chain of reactions that form that fibrin clot, okay? There are 13 clotting factors, including 2 plasma proteins, okay? And our 2 plasma proteins are factors 1 and 2, which are fibrinogen and prothrombin. But also, not only do we need those 13 clotting factors, and we need them all to go through this complex chain of reactions from beginning to end, but we also need vitamin K. Okay? It's used by the liver, which there tells you we also need the liver. There's multiple things in this process because the liver uses vitamin K in the production of prothrombin. So if you have severe liver disease, you may not be able to produce prothrombin because your liver's not working properly, which could cause you not to be able to clot, right? And you bruise easily. If you have a lack of vitamin K, which sometimes you see in people because of a poor diet, this is in every cause, but if you're not eating enough green leafy vegetables, you may need to make sure you're taking a vitamin, you have enough vitamin K. So we can see we have 13 clotting factors, okay? We have vitamin K and we have our liver. All these things work together to maintain hemostasis, okay? So this is the coagulation cascade, okay? And it's complex and it can be hard to learn, okay? But the things you need to start remembering is you have your intrinsic pathway and your extrinsic pathway, okay? So remember, if you see the things in red, these factors in red, these are the common pathways. There's things that are solely just to the intrinsic and solely just to the extrinsic, and there's things that is a common pathway that they use together. But you're wanting to go through this entire process and end up with that fibrin clot. And if you're missing any of these things like calcium, or if you're missing factor 1, or if you're missing factor 2 because your liver's not able to produce it because of liver damage or liver disease, or because you have a lack of vitamin K, you might not be able to clot as effectively. That's why you see people that sometimes when they have nosebleeds, it's because they may be deficient in vitamin K, because they're missing one of those things that needs to lead all the way down to that fibrin clot. Here's another slide that just kind of tries to break this down for you, because I know it's hard for everybody. So look on the intrinsic side, okay? You have all these factors that are just due to the intrinsic side. So if we're wanting to look at that intrinsic side and we're wanting to see these factors that are just for that, there's a certain test we do that. We do an APTT if we're looking for those factors. If we're looking for that one tissue, that factor on the extrinsic side, the extrinsic pathway, we use the PT, right? And then, like I said, there's common things that go in together that they both use to come together and form that fibrin clot. But also remember, you know, there's other things like calcium, vitamins, and lipids and other stuff, including your liver, that needs to be there for this entire process to take place effectively. It doesn't mean you can't clot at all, but you just not maybe clotting as well. Again, this is even a more broke down version. You see the intrinsic, it's factor 12, 11, 9, and 8. Okay, and then we do that PTT test for those particular factors in the intrinsic pathway. We have factor 7 in the extrinsic pathway. We do the PT test to check for that. And then we have the common pathway, right? Where we have factor 10, factor 5, we have prothrombin, which is factor 2 to thrombin, then fibrinogen, right? Then all the way to the fibrin clot, and there's 13 pathways. So if we feel like it's one of the factors 12, 11, 9, and 8, and we feel like that may be what it is, we would just do the PT test to check for that, right? But if we felt like it was factor 7, then we may do just the PT test. If we're thinking it's in the common pathway, or we don't know which one it is, we may do both the PT and the PT test. So we're still talking about that theory of hemostasis, right? What are the final steps in that clotting sequence? Okay, when you get down to the end, and these are these final steps, remember, thromboplastin is needed to activate prothrombin to become thrombin. Okay, so remember, okay, that thromboplastin is needed to activate prothrombin to become thrombin. Okay, which then activates that fibrinogen to become fibrin, right? So when prothrombin goes to thrombin and fibrinogen goes to fibrin, they both lose something. That'll help you. But remember, you need something to activate something else, and then that turns it into something else, right? So you guys can study this, just try to get it down, okay? So then we're still on this theory of hemostasis, right? And guys, another thing I just want to point out to you is on page 122 and 123 in your textbook is a really good white blood cell atlas that you can use, okay? And there's also some really good diff quick staining procedures at the bottom of page 125, okay? It goes into great detail showing you how to do that, okay? So now, how does the body stop the coagulation process and why? The body produces a normal anticoagulant, right? And we talked about how basophils play a part in this, right? They produce heparin. And it is in your bloodstream to avoid excessive clotting and the abnormal foundation of stationary clots called thrombus and traveling clots called an embolus. So remember, they're both clots. The thrombus is a clot and the embolus, they're both clots. And our body produces a natural anticoagulant inside our body called heparin, right? The difference between the thrombus and the embolus is the thrombus is a stationary clot. Like if you were to get a clot in a vein in your leg and it was just stopped right there and it wasn't moving, it was very stationary, that's a thrombus. If you had a clot that was traveling from somewhere else to say into your lungs, that's an embolus. Okay, so know the difference between the thrombus and the embolus and make sure you understand that we normally produce inside our bodies an anticoagulant called heparin. So how do physicians treat patients who are prone to forming internal clots? I'm sure you've heard of people that they have clots, right? Okay, so those patients who are prone to that, they're placed on anticoagulation therapy. And I'm sure you've heard of Coumadin and warfarin. They also can be placed on heparin. These patients tend to bleed longer after venipuncture, and you would need to make sure you held pressure for longer. This is why in our medical interview, we like to touch base with our patients to see if they're on any type of anticoagulation therapy. Now we want to talk about some testing we can do for this, right? So when our patient is placed on anticoagulation therapy, our doctor needs to monitor that therapy. So always remember, guys, whenever they put them on blood pressure medicine, they want them to come back to the doctor periodically and have their blood pressure taken and consult with their physician to make sure we're on the right diet, the right exercise routine, and we're taking our medicine properly. So we should see our blood pressure start to come down, our weight start to come down, and if not, we need to rethink our plan of attack with our patient to get our patient healthy, right? If we place our patient on an anticoagulation therapy, we need to do testing on them weekly, right? Because this is a very delicate process and we don't want it to get out of whack, right? So we want to monitor them weekly to determine the amount of time it takes to form that fibrin clot, because we may need to give them less therapy or more therapy based on their results. So here's one of our slides. Pause it now and see if you're able to put this together and answer this question correctly. Remember, if they're placed on an anticoagulant, they need to be tested weekly to make sure they're on the correct dosage, because that can change. Sometimes we need to lower the dose, sometimes we need to increase the dose, okay? And remember, your body's natural blood thinner is heparin. So now let's talk about our hematology stuff, right? So if we send a hematology test out to a reference lab, we typically draw a purple top tube that must be 100% full, right, from our vein, right, which would mean our specimen source would be venous, right? So if we're doing a CLIA waived hematology test, it's normally from skin puncture, whether we stick a finger or a heel. And honestly, most of these CLIA waived devices come with their only very specific collection device that you collect your capillary blood. If you see right here, there's a little strip sticking out of this instrument, and they're holding the drop of blood right up to that instrument, and that instrument will pull that drop of blood in by capillary attraction. But you need to use the strip that came with that specific instrument to collect that specimen. Always make sure you read your manufacturer inserts. Make sure you understand what supplies need to go. Never switch supplies from one machine to the other, and always specifically go by the manufacturer's directions. So I want you to be able to name the 4 CLIA-waived hematology tests and their instruments that can be performed in a certificate of waiver physician's office. We have hemoglobin tests, hematocrit, SED rates, and PT test, right? Prothrombin test. So the Hemacure or the Stat Site M are 2 tests that can be done for hemoglobin. The Hematostat is a hematocrit test. And then the SETI-Plast Westrogen is what we do for our erythrocyte sedimentation rate. And either the ProTime or the Coagucheck are CLIA-waived instruments for our Prothromb time test, okay? And then I want you to be able to name a moderately complex hematology test and its instrument that is commonly run in physician's office lab. It's the QBC, which is a quantitative Buffy coat, right? And that's where we do our complete blood test. Guys, there's a lot of great pictures in our textbook about these CLIA-waived hematology tests. Starting on page 129, 128, and 129, 130 gives a lot of really good info, going over to even 132, 133, 134, and then on page 135 it shows the SETI-Plast system and its setup, okay? So make sure you read your textbook first. There's a lot of pictures in there, guys. It doesn't take long to read these chapters, okay? Then come and watch these PowerPoint presentations, fill out your review guides. You will learn a ton, and then when you come into lab, you'll be ready to do these tests, okay? So we have that QBC for our CBC, okay? Here, right over here to the far right-hand side of your screen is the Hemacure, right? With a 12.5 showing on the screen. That's displaying the results of the hemoglobin that was ran on that patient. That middle picture is showing them use the very specific cuvette to collect your drop of blood into it that is only used with the Hemacure. Once you collect it, it will draw that blood in there by capillary attraction. You insert that cuvette into your instrument, and then you get your reading. Remember, the reference ranges for men always run higher than women because women lose blood every month due to menstruation. And remember, these hemoglobin tests test for anemia. Are you or are you not anemic? So what are the principles of these tests, right? So remember, like I said, you always want to collect the blood into the appropriate collecting device. You want to make sure that what the analyzer is going to do is hemolyze the blood. And then it's going to analyze the released hemoglobin by sending a light source through the specimen, right? It hemolyzes it, then it shines a light through it. The optical reader receives the light on the other side after it passes through the specimen, allowing it to calculate the amount of hemoglobin in the specimen. The instrument then produces a digital readout expressed in grams per deciliter. And then you will record that on your report form. And then you would put it against the reference ranges to make sure that your patient was not abnormal, okay? Also, here is the iStat point of care, which is another instrument that is a CLIA-waived instrument that you might see in a laboratory in a physician's office. It's also at the bottom of page 127 in your textbook, okay? Now, make sure you know these instruments and what tests they test for, okay? We also want to know about these abnormal, but why are we doing this testing, right? So when we do our hematocrit test, we talked about our hemoglobins for anemia, so is our hematocrit test. It tests for anemia, in which it is low, okay? And then polythysemia, which is high, okay? So if it's low, we test for anemia. If it's too high, we're looking for to be able to diagnose polycythemia, okay? So now we're going to talk about the principles of the microhematocrit test, right? It measures the percentage of packed RBCs that results after centrifuging a specimen and comparing the volume of the packed cells to the total volume of the measured specimen. RBCs normally occupy about 50% of the total blood volume. And you'll see, and there's pictures in your textbook as well, guys, of this instrumentation and how it's read, okay? So we would collect 2 microhematocrit tubes, right? And we would fill them 2/3 of the way full with no bubbles in them, put our finger over the end, stick them down into our clay sealant because we don't want our blood to run out. Then we put clay end down into the centrifuge, balance one on each side of it. We will spin them down. Once it stops, we will take them out and read them. Okay? If you look on page 134 of your textbook, it will show you the reading procedure and how it does it. And then it reads out a percentage for the first tube, and then you do it again for your second tube, and it needs to be within 2% of each other or you have to recollect it. Remember, the hematocrit value is approximately 3 times the value of the hemoglobin. So consequently, if we use that rule of 3, if you have a 12 hemoglobin, 12 times 3 is 36, right? And from that, we would have a 4 million RBC count. Okay, here's another slide. Pause this one, read it, and make sure you're getting the correct answers. Okay, so we're still talking about the hematocrit, right? And I talked about this, collecting your blood from a finger stick into 2 heparinized capillary tubes with no bubbles, right? Put your finger over the end, gently press it down into the sealant 2 times to make sure that it's sealed really good. Then you place it in the centrifuge, which is a part of this instrumentation. Place side down across from each other, close the lid and press run. It will spin it down. Once it finishes, the top will pop and you can take them out and you determine the percentage of RBC volume compared with the total blood volume by a built-in scale in this system. And like I said, page 134 in your textbook shows you exactly how that's ran out. We will do this in lab. The results of 2 tubes should fall within 2% of each other or the test should be repeated. So we understand when we split this down, first of all, we want to make sure we don't see any hemolysis, right? Because this is a light test, okay? So it does not need to be hemolyzed. We also don't want to see any heavy lipemia. That's where the plasma appears white and cloudy from high fat content in the blood. If we see that lipemia, we want to alert our physician to this because it can be an interfering substance in getting a correct and accurate lab result. We're going to have our clay at the bottom, our plaque red cells, our buffy coat, our plasma, and then air at the top, right? Be able to label a spun microhematocrit tube with each part. So you guys pause this and make sure you know where each part is. And if there was a blank picture with no labeling on it, could you label each thing from the clay sealant all the way up to the air? Here's another one of our case study critical thinking slides. I want to make sure that you're putting all this information together to be able to use it effectively out in the field as a medical assistant. So pause this now and see if you're answering these questions correctly. We always know that if we're talking about anemia, it's the hemoglobin and hematocrit test that we're doing, right? And we know that we draw it for the reference lab in a purple top tube that has to be 100% full. If we're doing it in a physician's office lab, we could stick a finger or a heel and use capillary blood. Pause your slide and see if you can put this all together and answer these questions. Always compare your results to the reference range to make sure your patient is not in a critical value. Remember, a wave test is the lowest of the 3 levels. You have wave, moderately complex, and highly complex, right? So now we're going to move on to our erythrocyte sedimentation rate, our ESR. And like I told you, there's a really good picture of this on page 135 in your textbook. So what's the principle behind the SED rate, okay? It is the rate at which your RBCs settle out of an anticoagulated blood specimen after an hour, okay? Plasma proteins, especially globulins and fibrinogen, increase during inflammation. And they cause the RBCs to become sticky and they stack together. You see an example of that at the bottom picture on the right in a rouleau formation. They resemble stacking chips. Once you have that, they increase the SED rate. So now you know that we do SED rates to see if our patient has inflammation, right? The further they drop down, the more inflammation the patient has. And if you notice on page 135 in your textbook, there's 3 SED rates there, and each one has a little further down, and you see the white marks, and that's where you read it, okay? You can see that on this picture some too. The third tube from the left-hand side, you can see a lot more plasma at the top than you can the first tube on the left-hand side, okay? Now, it's a non-specific screening test. We talked about doing screening tests. A lot of our WAVE tests are screening tests. So this is not going to tell us what is wrong with our patient. It's not going to tell us what inflammatory disease they have or what autoimmune disease they have. It's not going to tell us if they have a cancer or leukemia, right? What it's going to tell us is the degree of inflammation is going on in our patient's body. Okay? Now they may screen and say, oh, this patient has a high rate of inflammation. Now we need to do further testing to find out what's causing that inflammation. Then we may put our patient on some type of treatment and then have them come back into the physician's office at a later date and do another SED rate to see if our treatment is working. Because if our treatment is working, our test results should be better this time. There should be less inflammation, right? Now, there are some factors that can affect that SED rate. Some are beyond our control, like the size and shape of RBCs. But there's other stuff that we have control over as lab assistants, medical assistants, and phlebotomists, right? Blood must be fresh. We need a fresh draw of blood, okay? Any type of extreme temperatures in our labs, whether it's way too cold or way too hot, or leaving our tubes sitting near something that's too old or too cold or too hot, will affect the results, okay? Other things, tilting the test tube over can affect it. Vibrations, you never want to set your SED rate up on a counter where there's a low vibration of an instrument that's running or a centrifuge that's spinning, right? And if you allow that tube to go past an hour, we set a timer. And when that timer goes off at an hour, we need to read the SED rate immediately. The longer it sits there, you're putting out an erroneous result. It needs to be read at exactly an hour from the time you set it up. Air bubbles in the tube lowers the SED rate. Okay? On page 135 of your textbook, you'll see where you take the little, it's figure B, right? That's your little citrate tubes. You put the blood into them, right? You set them in the rack. Then you take your pipette and you push it down into it where the blood goes all the way up to the top. Start your timer for an hour, and then you read it once it's reached an hour. Venous blood is what we use for the SED rate. It's drawn in a purple top tube filled 100%. It can never be done by skin puncture. You would never get enough blood from the skin puncture to be able to do this test. It's always done from venous blood in a 100% filled purple top tube. So pause this slide and see if you're able to answer these questions properly. Okay, these are things you should be learning all along, and you're keeping this stuff in your mind, right? Okay, we run a SED rate to monitor a condition, some type of condition that's causing inflammation. we draw a purple top tube that's 100% full with the anticoagulant EDTA to do our test. It is a CLIA wave test that is done in physician's office lab, but it cannot be done from fingerstick. And we remember from previous lectures that EDTA works to prevent the blood from clotting by binding the calcium. And we know from our cascade that we need calcium to form a clot. So here, guys, stop it again. I want you to name 3 things that can interfere with running this test, this sed rate test, to ruin its accuracy. Remember, these are all things that we can control. Make sure you keep them in mind as you're setting up your lab, and make sure you don't set your sed rate up somewhere on a counter that has something running like an instrument or a centrifuge that's going to vibrate them. We don't want to get air bubbles in them. We don't want to tilt them. We need to set that timer and read it at exactly an hour and make sure we use fresh blood that it has not been exposed to any extreme temperatures. Okay, now let's move on to our prothrombin time, our PT test. So now we're going to start off with the principles behind it. We need to understand the principles behind this testing. If you don't understand how the instrument works, it will make you not understand why you need to do the things to get the correct and accurate results. Okay? So remember, it measures the amount of time the blood takes to form the fibrin clot. And we understand the fibrin clot is that 13th step down there at the end, right? It needs to form the fibrin clot. It uses thromboplastin as the active reagent to initiate the clot coagulation process. Okay? So why do we order PT tests, right? They're most commonly used to monitor patients that are placed on anticoagulants like heparin or warfarin or Coumadin, right? And we know that too little blood thinners shortens the PT time, and it could cause clots in the bloodstream and lead to a stroke or a heart attack, right? It's also used to screen patients who lack clotting factors, who have liver disease, or deficient in vitamin K, which is a crucial element in the production of prothrombin. So these are all the conditions that we use the PT test to check for. So you also want to be able to name the CLIA wave instruments used for prothrombin time test. We have the ProTime and the CoaguCheck. There's a picture of the ProTime. Okay? And you need to know what type of blood needs to be drawn for which instrument. Your lab may be using the ProTime, or your lab may be using the CoaguCheck. Okay? The ProTime, you need to draw a light blue top tube that must be filled 100%. It cannot be done from a skin puncture. The CoaguCheck actually can use fingertip blood, okay? So the results of the ProTime are expressed in seconds, okay? And as an international normalized ratio, which is INR. The INR is used to compare the results of the different methods of doing the test, whether you're doing it in the physician's office lab or in the reference lab. So we understand that when we do a CLIA wave test in a physician's office, that off of capillary blood, okay, or if you do it off of a blood tube, it's going to be quite different than those big expensive tests done in the reference lab. We use the INR to compare those results, so we'll understand, so the doctor will have all the information he needs to compare that result to the one he's getting in his office, so he'll see if they're on the right amount of anticoagulant. These are reference ranges that you guys will need to know. There's a study guide in your black binder based off these reference ranges for one of your lab quizzes, okay? So I hope you've been studying those, because you're going to need to know these reference ranges. So here's the reference range for our hemoglobin, which is 12 to 18 grams per deciliter. Then there's a hematocrit, 36 to 55%. Sed rate is 0 to 20. And our ProTime is 16 to 18 seconds, or 2 to 2.5 INR. Guys, start memorizing these, okay? because you need to know what the reference ranges are so that when you get your patient results, you will immediately understand if it is something that is a panic or critical value, so you can immediately notify your physician. Pause this slide and see if you're getting the right answers. Here's another one. Like I said, guys, I want to make sure that you're able to put all this stuff together, you're learning, so when you're out there working with patients, you're going to be making those right critical thinking decisions. So pause this slide now and see if you get the right answer. Remember, charting is important. It's how we communicate with our coworkers and our physician. Pause this and make sure you're still keeping up with how to do your charting. Okay, remember the difference between charting something that is normal versus something that is abnormal. That's why we need to learn these reference ranges so we can immediately spot an abnormal, especially critical or panic values, so we can notify our physician immediately, because these are values that shows our patient is in trouble and we need to take care of them. And remember, do you fill out the test performed by section on your requisition form? Yes, if you ran the test, right? It shows who ran that test. Okay, so guys, make sure that you go through this and you understand all this stuff, okay? So let's move on to our complete blood count, our CBC, right? We understand that it should be drawn in a purple or lavender top tube. It should be filled 100%, and it has an additive, and its additive is EDTA, which is an anticoagulant. It stops the blood from clotting, which makes certain that we will be using whole blood, because when we do a CBC, we need whole blood, not spun down, but whole mixed together blood. So we also need to understand that it is a moderately complex, it's not a waved, right? We have waved, moderately complex, and highly complex testing under CLIA. This one is not waved, it's moderately complex. From studying for your profiles and panels test that you took, you understand the 7 tests associated with the CBC. First, we count the cells, right? The RBCs, the WBCs, and the platelets. It also gives us a hemoglobin and hematocrit, and we use that for anemia, right? And then it gives us our RBC indices, and we'll get to in this slide why we need those RBC indices and what they're used for. And then the machine spits out an automated differential count that you've already learned what that differential count, whether it's automated or manual, can be used to help diagnose our patients, right? And we also know that when it comes to reference ranges, they're going to vary. We talked about men and women, right? They vary between men and women. They vary from different stages of your life, from geriatric to children, to infants, right? The reference ranges are not going to be the same for everyone, okay? They also vary in the country. If you're living up in the Rocky Mountains in Colorado, your altitude is much different than if you're living in the flat delta of Mississippi, right? So Mississippi's reference ranges are going to be different than those that are in Colorado, right? Other things like your temperature levels, your humidity, and all these things play a part in those reference ranges. So that's why CLIA states that each lab needs to have its own normal set of normal values or reference range that go along with each and every test, and they need to be included on report forms so that you can compare your patient's results to those normal values, right? So here is the homework that's inside your review guides. So make sure you fill these out because you turn your black binders in for a grade, right? So in your own words, tell why reference ranges are not the same from lab to lab around the country. Guys, learn how to speak intelligently by using the proper words. In healthcare, it's very important. You want to be able to communicate with your physician, your co-workers, and your patients. You want to be able to explain these things in your own words correctly, okay? So you want to make sure that when you're writing this down that your answer contains that reference ranges are not the same from place to place. They differ with the temperature, humidity, and altitude of the area that you're living in. And this is why CLIA wants each lab to establish their own reference ranges. So what is the name of the CBC run on an automated hematology instrument? We call it a hemogram, okay? So again, we have a study guide inside your black binder for all the reference ranges, and we understand that men are 4 to 5 to 6 to 0 million per cubic millimeter and 4 to 5.5 for women. Women are going to be a little less because we talked about this before, because they lose blood during their menstrual cycle. And these are RB indices. And we're going to go through these and we're going to understand that they are important. They're a part of our CBC and we want to know what they do and why they're there. Okay, the thing you guys need to remember is these are mathematical ratios and they help our physician in diagnosing the cause of anemia, right? We know our hemoglobin and hematocrit says the patient is anemia, right? And the hematocrit also say they have polycythemia. But we need to remember there's different kinds of anemias out there. And we need to understand that the MCHC, which stands for the mean cell hemoglobin concentration, is used to diagnose anemia and polycythemia, right? The MCV, which means mean cell volume, tells the size of the RBC, and the MCH is the mean cell hemoglobin, and it tells the concentration of the hemoglobin in the RBC. Guys, you're going to need to know what each one of these means and what they're there for, okay? So remember, they're mathematical ratios that help in diagnosing the causes of our anemia. These are the formulas for the RBC indices. And yes, you're going to need to know them, okay? So the MCHC, that's the bigger one, right? There's 4 letters to that versus the 3 for MCV and MCHC. And the reason I'm saying this is because these are just little tips that will help you memorize them. So more letters, right? Bigger number. Because you can see it's the only one with 100, right? And we see that it's the only one with the hemoglobin and then the hematocrit at the bottom, okay? MCV is the hematocrit times 10 over the RBC, smaller number, right? And the MCH is the hemoglobin times 10 over the RBC. Okay, so now here's some more study tips. Both the MCV and the MCH have the 10 on the top, right? Smaller number, smaller amount of numbers there, right? The MCV has to do with the hematocrit. So you think of volume. Remember when we talked about filling up the microhematocrit tubes and then spinning them down, and you're talking about the packed cell volume? So let that PCV help you remember that the V is for volume, that's hematocrit times 10, right? Then the MCH, H, hemoglobin, right? Hemoglobin times 10. So these are just small things. The MCHC is bigger, so we have a bigger number of 100. And we know that's hemoglobin and hematocrit, right? We know these two are smaller, so they're both times 10, and the RBC is the under number, right? And then we have hematocrits with the V for volume, packed cell volume, right? And H for hemoglobin. So these are just things I'm trying to give you tips to help you be able to memorize this, because you need to know it and memorize it, okay? And remember, our doctor uses these indices to help tell what other things, what type of anemia our patient may have. Okay, again, there's a study guide in your black binder that is dealing with your reference ranges. You guys need to learn these reference ranges. It's going to be hard for you to be able to catch a panic or critical value if you don't understand the reference ranges. So a normal is 4 to 11 on our white count, right? If it's slightly high, it can indicate a bacterial infection. We talked about that. And then you're going to have an increased percentage of your neutrophils, right? If it's extremely high, that could indicate leukemia. And if it is low, it could indicate a viral infection. And along with that low, we would also need to see an increased percentage of lymphocytes, right? Okay, so our platelet count is 150 to 400. Okay, so here's one of those things, okay? So pause this and see if you're getting the right answer. Pause it now. Because remember, 4 to 11 is normal. So 15 is high. It's quite a bit above 11. And because it is high, that could give us an indication that she has a bacterial infection. 70,000, though, that is extremely high. And that's indicating that she could possibly have leukemia. Of course, we wouldn't use these things as our only thing, but they are real big indicators of what could be going on with our patient. We know 4 to 11, right? 2-5 is low. We understand that with a low white count and an increase in our lymphocyte percentage, it really points strongly at a virus. And we want to make sure we know if our patient, because a lot of times bacterial infections and viral infections can mimic each other on their symptoms. So if we do these white tail sounds and these differentials, it can distinguish between the bacterial and the virus, because antibiotics will not work on a virus, right? And we don't want to give people antibiotics if we don't need them. We don't want to overuse antibiotics. But we also want to make sure if it is a virus, we treat them properly as well. Know your normal ranges. Okay, so now we want to identify anemias, right, and give a description. We have the folic acid deficiency anemia. That's from an obvious folic acid deficiency. Around in the 90s, they started putting folic acid in orange juice because we had such a large population of women who were having folic acid deficiency, and it could cause a lot of problems during your pregnancy. That's why it's so important for health concerns for us to eat a whole foods, plant-based diet. Most of your plate should have green leafy vegetables on it, okay? Then we have iron deficiency anemia that's caused by blood loss, which could cause a deficiency in iron, such as your period, or if you had a bleeding ulcer, or honestly, if you had a large cut or incision and you were bleeding. Then you have hereditary spherocytosis, which is sphere-shaped RBCs. And when they're odd shaped like that, remember when we're scanning that differential slide, we look for the size, shape, and color of our RBCs to indicate issues, right? Because they're funny shaped, they can't carry the oxygen. The RBCs can't do their job properly, and it's caused by genetic abnormality. Then we have what they call aplastic anemia. It's caused by the destruction of stem cells in the bone marrow from certain toxins. Think of bone marrow as being plastic. That's just a little study tip to help you, because you need to know each one of these anemias. We also have pernicious anemia. It's caused by the decrease in vitamin B12. Okay? And then we have sickle cell anemia, which I know a lot of you have heard of. It's caused by an inherited abnormal hemoglobin S. Thalassemia is a hemolytic anemia caused by inherited abnormal hemoglobin, and hemolytic anemia is caused by the destruction of RBCs. Now let's talk about WBC's disorders. So we talked about this, right? What does a rise in neutrophils indicate? It indicates the bacterial infection, and the rise in lymphocytes indicate a viral infection. And over to your right at the top is a segmented neutrophil, and down in the bottom is our lymphocyte. Remember, our lymphocyte is one of our smallest WBCs. What does an increase in atypical reactive lymphocytes indicate? You see a lymphocyte, you see a monocyte, and then you see an atypical lymphocyte, okay? Atypical lymphocytes indicate mononucleosis. So here's one of those concepts where you want to be able to take things and put it into your own words. This is showing that you understand the process and you can explain it to someone. So make sure you fill this out in this space, okay? In your own words, you want to describe how the different types of WBCs and the differential can be used to diagnose a bacterial infection, a viral infection, and mononucleosis. Make sure your answer contains that bacterial infections show an increase in neutrophils, viral infections show an increase in lymphocytes, and mono shows an increase in atypical lymphocytes. So pause this one right now and see if you are putting this all together and can answer these questions. Guys, especially for medical assistants, this is vitally important that you're putting all this information in lab and lecture together to see if you can figure out what is wrong with your patient. Pause this now and see if you can answer these properly. Remember that purple top needs to be 100% full. It's additive. It's an anticoagulant called EDTA. And remember, those increased number of atypical lymphocytes indicates mono. So we want to identify the following types of leukemia, right? AML, CML, ALL, right? Now, there's two types, acute and chronic. You'll see, okay? So acute myelocytic leukemia is that sudden increase in immature granulocytes, okay? And then we have chronic myelocytic leukemia, which is a more gradual long-term increase in those immature granulocytes. So we see an acute, it's sudden, all of a sudden a real spike in immature granulocytes. With CML, it takes time. And each time you're doing they're coming to the doctor and they get their blood drawn, they do their CBC, we slowly but surely see these immature granulocytes going up over time. That's why it's so important to go and see your doctor annually for your visit and have your lab work done so that they can catch any of these things that are going on. We also have acute and chronic lymphocytic leukemia. So in ALL, that's a sudden increase in immature lymphocytes, and it is very common in children. But it can also be chronic in the fact that it can be a gradual long-term increase in those immature lymphocytes. Again, guys, pause this now, read through it, and make sure you're getting the correct answer. Remember, ALL, acute lymphocytic leukemia, it is common in young children. These are all things that if you know them, you can all put them together. We wouldn't diagnose based off one thing, but when we put all of our diagnostic tests in with our symptoms, our history, and other things, we can help our doctors be able to diagnose our patients and then treat and monitor them. Okay, if a doctor's office needs more CBC information than just the hemoglobin and the hematocrit, which we know there's hemoglobin and hematocrit tests out there that are waived CLIA tests, okay? If they need something more than that, they can purchase a automated hematology instrument. But we understand that these are moderately complex, right? But they also need to be the type of instrument that is approved for moderately complex and not highly complex. So there's some extra step that lab will need to go through if they're going to perform moderately complex tests. And like I said, first and foremost is you make sure that your instrument is approved for moderately complex testing. Then you need to train anybody operating that instrument, and it must be documented. Not only must you document the training, but you must have competency testing for each and every operator that operates that instrument, and that must be documented. You must have detailed records of the instrument calibration and maintenance per the manufacturer guidelines. You must run and log 2 levels of liquid controls each 8 hours of a shift, and you must do proficiency testing. So now let's talk about the CLIA wave moderately complex automated hematology system, which the one we're going to talk about is the QBC star centrifugal hematology system. Okay, the QB system performs a CBC by spinning a capillary sample of blood into its various layers, red blood cells, buffy coat, and plasma, right? Then a fluorescent dye, which is included in this aperture that you see over here to the right. This is where we collect the blood in this, right? In that fluorescent dye and a miniature float, which is also included in that device. They can stain and spread out the buffy coat of WBCs and platelets into 3 additional layers: granulocytes, non-granulocytes, and platelets. And if you look on page 142 of your textbook, it'll show you that little device, right? So remember, any of these devices, a lot of these devices have their own specific collection tube or cuvette that you have to collect your blood in, because it has things like that fluorescent dye and the float that it uses to be able to run the test. We also have what they call the Coulter counter system. Now, the Coulter counter performs an automated CBC, and the way it does it is blood is diluted with an electrolyte solution. Now, this solution can conduct electricity. Then it has a little aperture or opening in it, and you'll see it in your documentation right there. And then each time a cell goes through that aperture or opening, it causes an electrical impedance of the circuit. Okay, and the instrument knows by the way it comes through there and the impedance that it causes, or the interruption that it causes, if it's a red cell, if it's a white cell, or if it's a platelet. Okay, then those pulses are counted and analyzed and calculated by the instrument, and then it produces a readout that tells you all the 7 different tests that are included on a CBC. Now, these are some outdated or rarely used hematology devices for CBC. The thermopipette is outdated. It is not used. And the reason it's not is because if you'll notice, there's a glass pipette and attached to it is a rubber, looks like a rubber hose, right? Well, you would use one end to attach to the pipette, and the other end you would put in your mouth and suck the blood and the diluent into the tube. You can see how when we learn, when we know better, we do better, right? And now we know that we would not be wanting to do something like this. So this is not used anymore, but it could be asked on some type of test, and you would want to understand and see what this is. And then the unipet is rarely used, but if your CBC machine goes down, or if you work in maybe you went to work in a vet's lab or somewhere like that actually used manual WBCs, RBCs, and platelets, you would use the unipet system to collect that blood. Now, these are just collection devices, guys. Well, they're mixed with a diluent, right? From there, you put that mixture into the hemocytometer, which is a slide used for manual counts of WBCs, RBCs, and platelets. Okay? After they're diluted with those, either the unipet or the thermopet pipette, blood is then placed on the slide and the cells are counted. Okay? This is rarely used, but you do need to know about it because you might actually go to work somewhere in a rural area. I don't know if some of you are going to go to another country. You could go to Africa. You could go to India, right? You could go to work in a vet's office or a really rural clinic that they have an older machine. If it goes down and you need to do a WBC count right now, you can actually do it this way. So in summary, this chapter, we talked about proper specimen collection for hematology testing. We talked about blood components found in the bone marrow and the peripheral blood and how they develop. We talked about that stem cell, right? We talked about how to perform blood smears and stain them. The basic principles of hemostasis and coagulation, right? We talked about 3 waved and 1 moderately complex hematology tests. We talked about performing QC on CLIA waved hematology tests, how to perform hemoglobins, hematocrit, PTs, and SED rate, which are all wave tests. We talked about the major uses of these tests. What are we using them for? Okay? We talked about the 7 tests that are included in that CBC, and we talked about why RBC indices are even done and what are their significance. Okay, guys, here are these key terms and some questions that you can use like flashcards to study. I'm going to go through these very quickly, but you guys can pause right now, and I'll give you a few seconds in between each key term to be able to pause it and see if you're getting the right answer. Pause now. Again, we talked about the significance of WBCs and differentials. We talked about the QBC and the Coulter counter method for CBC testing. These are some review questions. I'm going to go through them quickly. You can pause them. I'll give you a chance after you get the answer for number 1. When the second question comes up, I'll give you a minute to pause it. You can use these as flashcards. Pause now. Okay, guys, so that's that chapter. It's long. There's a lot of information there, but make sure you read chapter 5 in your textbook first. There's a lot of great illustrations and examples in there. Then watch these PowerPoint presentations as you fill out your review guides. Then study your review guides and get ready. This test will be here before you know it. You guys have a great day.